Hello and welcome. Thank you for joining the Systems for Action Research in Progress webinar. My name is Chris Lytle and I am Deputy Director of Systems for Action. S4A is a national research program of the Robert Wood Johnson Foundation housed at the Colorado School of Public Health. We support studies across the country, testing tools and models to facilitate multi-sector collaboration across medical, social, and public health systems with a goal of improving population health and advancing health equity. Our RESPROG webinar series serves as a platform for S4A investigators to share findings at various stages of their studies and provide commentary on the potential impact of putting those findings into action. Today we are joined by Dr. Venice Williams and Dr. Gregory Tung to introduce their new S4A study that tests the effectiveness of multi-sector financing and delivery strategies in expanding the reach and impact of the Nurse Family Partnership Program in the US. Their presentation will be followed by commentary from Chris Aristides of the Nurse Family Partnership. If you have questions for our investigators, we'll follow up the discussion and commentary with a Q&A session. So please enter any questions you have along the way in the Q&A box. And we'll make time at the end for questions. So just a quick introduction of our presenters. Dr. Williams is a mixed methods prevention researcher at CU Anschutz Prevention Research Center for Family and Child Health and an adjunct instructor in health systems management policy at the Colorado School of Public Health. Dr. Tung has research interests related to how scientific evidence is incorporated into policy and program decision-making with a special emphasis on injury prevention. He works on a diverse range of injury topics, including the prevention of youth violence, suicides, poisonings, and child abuse. Dr. Tung's research interests also include the integration of health services and public health systems with a focus on nonprofit, hospital, community benefit activities. Chris Aristides is Manager of Healthcare Integration and Strategic Partnerships of the Nurse Family Partnership National Service Office. And with that, I will pass things over to Dr. Williams.
Okay, hi everybody. This is actually Greg Tung. Not Dr. Williams. Don't worry, you're going to be able to hear from Dr. Venice Williams in a little bit. So Chris, thank you for the introduction. And the very first thing that I want to do is to point out that even though Venice, myself, and Chris Aristides have the privilege of presenting to you today, our project, work leading up to it, and work moving forward is really a collaboration and a product of many other people as well. So I just want to take a moment to recognize them. Including Mandy Allison, who's also one of the principal investigators on this particular project, members of our core project team from PRC, including Mike Knutson, Connie Lopez, Carol Franco. They're like the engines that make everything work. And some of our other collaborators and members of the advisory committee, including Dr. David Olds, the founder of the NFP. Chris Aristides is listed here. You're going to hear from her in just a little bit, so you can look forward to that. And also Jade Woodard. Okay, next slide, please. So just starting off at a very high 30,000 foot level, the purpose of our project is to look at nurse-family partnership and the collaborative relationships that the program has with key institutional partners, with a special focus on multi-sector financing and delivery strategies. And all of this is to understand better what influence these dynamics, systems dynamics, collaboration dynamics, have on the reach and the impact of the Nurse Family Partnership, and how it actually influences the clients that the program serves and the population that the program serves. And we're going to be doing all of this using a mixed methods approach. So we'll, of course, dive into many of the details related to our project, but first we're going to spend a little bit of time giving you relevant background and motivating the project too. Next slide, please. Okay, so just a tiny bit of motivation here. So there are some things in the United States that we do well, and there are some things that we don't do as well. Can't help but say that. I feel like I'm potentially wading into a political minefield, so I'll try to avoid the mines and just charge forward and say that one of the things that we don't do well is maternal and child health. And that's evidenced by the fact that adverse pregnancy outcomes are more common in the US than any other developed country. And that these adverse outcomes are really concentrated amongst women living in the greatest disadvantage, including those women living in poverty. Next slide, please. And so what can we do about it? What interventions are available to us? So one of the most evidence-based, I'll just say it, the most evidence-based intervention that addresses these particular issues is the nurse-family partnership. So in a nutshell, the nurse-family partnership is a nurse home visitation program that's designed for first-time low-income mothers. And in the program, a trained nurse visits and delivers the program to mothers and their babies from early in pregnancy until the child is 2 years of age. And so the purpose of the program, or the intent of the program, is to produce improved short-term health outcomes, birth outcomes, but also longer-term health and development outcomes, and also much longer-term educational attainment and economic self-sufficiency outcomes as well. Next slide, please. And so here is a picture of David Olds. He's actually the founder of the Nurse Family Partnership. And I think there's a compelling personal story that I'll be very brief with, but it's also illustrative and gives, I think, valuable background on the program and its creation. So David, as a freshly minted graduate of Johns Hopkins University, didn't zoom off to graduate school right away. Instead, he graduated and he took time off and he worked in a daycare center in inner city Baltimore. And while he was there, he observed firsthand the effects that children, even very young children, preschoolers, were already experiencing and facing as a result of concentrated disadvantage. And it was also during that time that he had the idea or came to the realization that intervening earlier, prior to any of the effects of that concentrated disadvantage really taking hold, would be ideal, even prior to birth. And also that pregnancy represented this window of opportunity where positive changes could be introduced and possibly the mother would be more receptive to. Next slide, please. Okay, so fast forward to modern day. David, after that period of time working in inner city Baltimore, went off to Cornell, got a PhD, and went on to develop the NFP. It's a jarring and fast movement. We're now 40 some years later. But what I'll say is that one of the defining features of the NFP is a commitment to scientific research and evidence, both in the program's creation, in the implementation of the program, and in ongoing quality improvement efforts. So that entire body of research and evaluation is too large for us to catalog right now. But what I'll do is just touch on what I see as the backbone of that research. And the backbone of all of the research that's been conducted are the 3 randomized control trials that you see listed here. And so the first randomized control trial took place started in 1977 in Elmira, New York. It served primarily a population of low-income whites. The second randomized control trial began in 1990 in Memphis, Tennessee, and served a population of primarily low-income blacks. And the final randomized control trial started in 1994, was conducted right here in my hometown of Denver, Colorado, and served a large portion of Latinx in that particular study. And what all of these randomized control trials and other research has shown are persistent outcomes in kind of those 3 domains that I talked about earlier, like program effectiveness and outcomes in near-term health and pregnancy, also kind of longer term health and development, as well as very long-term educational attainment and economic self-sufficiency. Next slide, please. Okay, but the Nurse Family Partnership's not just a big research project. In 1996, community replication began. And some of the aspects of that replication, Chris Aristides is going to talk about in a little bit, but what I'll just touch on is that one of the objectives in that replication has been to maintain fidelity to the program and produce the same outcomes that were persistent in the 3 randomized controlled trials and other subsequent research that's been done. So this community replication is run by an organization called the National Service Office. It's also located right here in Denver, Colorado. And some of the outcomes that the program has been successful at having impacts on in replication include, but are not limited to, reduced preterm birth, increased breastfeeding, increased child immunizations, and improved educational and employment outcomes. Next slide, please. Okay, and so this slide kind of touches on some of the principles that I talked about in the previous one, which is a really very strong focus in implementation community replication at maintaining fidelity to the model. So let's see, points 1 through 4 here. 1 is develop it well. 2, test it thoroughly before investment. 3, replicate carefully. 4, and improve continuously. And I think this just reinforces this idea of maintaining that fidelity to the model, being consistent with the underlying evidence base that is the justification for the NFP. And I'll use this as an opportunity to pivot, and I think it's the reason why we are here talking with you now, and that is, I think through the decades, the NFP and the research surrounding the NFP is really focused on ensuring that there's something good there, right? That the program is producing persistent effects. And I think in replication in the program has really gotten to that particular place. And actually during the entire my involvement doing research with the NFP, I think there is an increasing realization and an increasing focus that the impact of the NFP and the impact that the program is able to have on clients and the population that it serves is really strongly influenced by its collaborative relationships with other key institutional partners. I think another way to put it is its broader systems context and how it fits within that broader system, which I think is the underlying reason why we're here talking to you now as part of as a Systems for Action grantee, and that now, and the focus of this project is really looking at those collaborative relationships, that broader systems functioning, and what type of implications does that have for the ability of the NFP in collaboration with other key institutional partners to have an impact on the clients and the populations that the NFP serves. So that's probably enough from me. And so we're gonna break the mold here a little bit. And Chris Aristides, who is officially our commentator, is going to jump in the middle of our presentation and talk to you some about implementation of the NFP, which is very important context for our project. So next slide, and Chris, it's all yours.
Great, thanks, Greg. Yes, you're going to get to hear from me twice during this presentation. I'll talk a little bit about the Nurse Family Partnership National Service Office to provide context, and then come back at the end to provide the commentary after Dr. Williams shares the project we're working on. So the Nurse Family Partnership National Service Office, or NSO as we call it, contracts with and provides support to local organizations that actually deliver the intervention. Our primary role at the National Service Office is really those 2 bullet points you saw on the slide earlier that Dr. Tung presented on, and that is, how do we replicate this model very carefully and improve it continuously? So our role, we educate the nurses across the country in the model. We provide a data collection system and reporting. We support our sites on advocacy and ways to support their local implementation, and then also support organizations that might be interested in becoming a Nurse Family Partnership site. Our sites, or network partners as we call them, come from a variety of different organizational homes. The bulk of them are in public health departments, either county or state level or local public health departments. And then we have a significant number of network partners that are in community-based organizations, and an increasing number that are in health or hospital systems or healthcare-related organizations. In addition to the hospital and health system network partners, we've also seen an interest and an increase in network partners that are in public health or community-based organizations forming either formal or informal partnerships with health systems to support their work. And most of ours are in the health systems, but we also have one managed care organization that's implementing nurse-family partnership, and we have NFP connected with federally qualified health centers, VNAs, and other healthcare-related services. I think that sets the stage for this research that Dr. Williams is going to talk about. Next slide. So currently, since 1996, we have served about 100,000 families across the United States. We're in 41 states, including the U.S. Virgin Islands and some tribal communities. And RAND Corporation and other health economists have done multiple evaluations and looked at about a $5.70 return for every dollar invested, and particularly on those families that are of the highest need, the highest risk families, which we strive to serve. Next slide. So about this point in the presentation, many people start to wonder, well, who pays for this? How is nurse-family partnership funded? How do we actually do this work? So if you go to the next slide, I'll dive into that. The first box there on the left, you'll see is where the original funding came from for the 3 randomized control trials that Greg mentioned earlier. These were really foundational in nurse-family partnership and were funded from a variety of different foundations and grants, including the Robert Wood Johnson Foundation. In '96, we began our community replication of the nurse-family partnership across the country. And the largest source of funding for the beginning of community replication after the trials was from the Department of Justice, who funded 6 of our first NFP replications. Over the years, as nurse-family partnership grew, states and local communities sought and received funding from a variety of sources over the years, including some of the bigger ones listed there. And again, Robert Wood Johnson Foundation has supported us significantly over the years. And in recent times, the most significant investment has been the Maternal, Infant, and Early Childhood Home Visiting Initiative, or we call it MICV. This is a federal grant that is administered by states and that most of our states are able to take advantage of to support nurse-family partnership. And if you go to the next slide, I'll talk a little bit more about where our current funding sources support NFP today. So right now, about half of our sites in about 22 states receive Medicaid financing in some form or another. And most of our states also receive the MICV federal grant that I talked about. The other sources are listed here. We've got state and local funds that also support nurse-family partnership. One of the more interesting funding sources that we have embarked on recently is the Pay for Success or Social Impact Bond pathway that we've been doing in South Carolina and is wrapping up now. We do have a variety of funding streams, as you can see, but even with these, we're really only serving a small percent of those who could benefit the most from nurse-family partnership. And next slide. So my role within the Nurse-Family Partnership National Service Office is really looking at how we can intentionally align and partner nurse-family partnership at the community level with both healthcare payer and delivery systems. This is part of our strategic plan for growth and for sustainability of NFP. On the delivery side of healthcare, we look at the operational structure of NFP and how they can function within that health system. This includes considering what service line NFP may fall under, how nurses can use or access electronic health records, and how NFP can fit within a health system's goals and structure. On the payment side, we're exploring Medicaid payment opportunities, both current and future opportunities, and how we can partner with managed care organizations which administer Medicaid funds in most states. With a growing interest and the use of capitated care and value-based payment structures, NFP outcomes and our national to local structure, the way we're set up, really positions us well to determine how to engage on newer healthcare payment opportunities. And on that note, I'm going to pause and turn over to Dr. Venice Williams, who will share with you the heart of the show today, the research project that is the topic of today's session.
Thanks, Chris. Thanks, Greg. Thank you for setting up the background and the motivation for this particular project. I think they provided really nice context for the practice need for our work and what we're hoping to accomplish through the Systems for Action project. And I'll talk a little bit more about the translational nature of what we're hoping to do. In a nutshell, our project looks at the delivery and financing alignment that Greg talked about in terms of NFP alignment with other cross sectors in healthcare and social services, to think about what are the effects on the reach of the NFP program and its impact. And so you see on the slide the three major aims of our project. I'll dive deeper into each of these here in a second, but as an overview, the first aim is to look at collaboration over time. And then in aim 2, looking at the relationship between collaboration and program outcomes. And I'll talk more about what those outcomes are in a second. And then third, to identify best practices that we can replicate. And so all of this is using a mixed methods approach, in particular using an explanatory sequential mixed methods. And I'll dive into deeper the methods for each of these aims. But first, I wanted to provide an overview of the conceptual model that drives our thinking and drives our approach to modeling in our particular aims. And so Greg mentioned the evidence base behind this program and some of the outcomes that Nurse-Family Partnership is able to achieve in the families that we serve. And some of that is driven by, most of that is driven by the ability for us to improve our family self-efficacy, to engage in certain behaviors, healthy behaviors. And so how does organizational collaboration or alignment between systems fit into this? On the left-hand side, you see organizational collaboration, and we define that as a combination of both systems alignment and interpersonal factors. And so the systems alignment includes that financial alignment that we were hoping to explore in this particular project. But we also know that in addition to systems working together involves people, and individuals we are relational in nature. And so we need to consider interpersonal factors that might drive collaboration. And so the idea here is that better collaboration would lead to increased care coordination, and through better care coordination, we're able to meet the needs of our families in this program. And with that, we're then able to implement the program with fidelity to the model to improve our family self-efficacy, hopefully leading to better outcomes. And all of this is influenced, of course, by client-level socio and demographic factors, as well as nurse-level characteristics, and also agency-level factors. And so throughout the rest of the presentation, when I'm talking about agency or sites, I'm talking about the specific local network partners that Chris talked about, which are the particular organizations that are implementing NFP in the community. And so that's the overview of the particular conceptual model for the broader project. And I will dive deeper now into our first aim, which looks at measuring collaboration over time. And this is really thinking about in response to some of the naturally occurring efforts that Chris mentioned in terms of healthcare integration, but also some of our funding changes that we see from state and local and federal dollars coming in to fund Nurse-Family Partnership implementation. And so to answer this particular research question, we'll be using a longitudinal survey methodology to measure nurse collaboration with other public health, healthcare, and social service providers and sectors. And so at this point, you're probably wondering how we're measuring or conceptualizing collaboration. And so for the survey in this particular aim, we'll be measuring collaboration using relational coordination and structural integration. And so I'll talk more about these two concepts here in a second, but really wanted to motivate this work by saying that this is driven by previous work we've done with qualitative work, but also a previous survey instrument that was developed to measure collaboration. So we'll be using that same instrument over time to measure collaboration changes. And so with that, wanted to spend some time to talk about relational coordination and structural integration. And so on the left-hand side, you see a diagram. Excuse me, that's my dog. Relational coordination is the idea that coordination is driven by high-quality relationships coupled with high-quality communication. And so what is high-quality relationships? Well, you see that on the left-hand side of this left-hand diagram, that relationships are based on shared goals. So to the extent to which different sectors and organizations and providers share goals with one another to serve families, to what extent do they share knowledge about each other's roles and responsibilities, and do they respect one another? And then in terms of high quality communications, it's determined by the frequency of the communication. Is that communication timely? How accurate is that communication? And is the communication problem solving in nature? So that's how relational coordination is captured. We use a 7-item validated scale by Jody Gattel out at Brandeis University. So that's relational coordination. In addition to that is the structural pieces that we're interested, especially for this particular project, thinking about systems alignment. And so across these different systems and different providers, to what extent do they share physical space? And so that can be a building, a campus, a facility space, or a clinic. At the same time, we want to capture shared policies that might exist to facilitate coordination and collaboration. And so those might be more formal in nature. It could be a memorandum of understanding. It might be something less formal in terms of some established work process in place. In addition, shared data and information systems. I think the easiest example of that would be shared electronic medical records or shared electronic health records. And then finally, shared funding, which is a financial alignment piece that we're particularly interested in exploring in this project, looking at, where are there shared funding opportunities or specific mechanisms in terms of funding nurse-family partnership implementation. And so that's our first aim in thinking about measuring collaboration and collaboration changes over time. With that leads to our second aim of this project. And so now that we've measured collaboration, we're interested in exploring the relationships between better collaboration and program outcomes. And for us to be able to answer this question, we'll be using random effect models, or depending on who you talk to, they're mixed models or multi-level models. Essentially, we're trying to control for nested data. So we have multiple clients who are served by the same nurse. We have many nurses who exist within the same site or network partner. And so that's the modeling approach we'll be using for that, including client, nurse, and site level factors as well that might contribute to the outcomes of interest. Here, we're specifically going to be looking at the differences in outcomes between NFP sites that are financed by healthcare systems versus those who are financed by social service sectors. And so Chris talked about how NFP in replication and community has been collecting data as a function of continuous quality improvement. And so what we'll be doing is pairing nurse-family partnership data, program implementation data with the survey data that was collected in aim 1 to answer this. And so you're probably wondering what outcomes we'll be looking at. And so previous work we've done, and I'll talk a little bit more about that later on in this presentation, has looked at collaboration and program implementation measures. And so in a program that's implemented across the nation, we're interested in certain features of implementation. And so that includes things like client retention, where we know that if we don't retain our clients through the entire duration of the program, we may not see the intended effects of the program. So that's kind of an intermediary outcome that's of interest. We are also going to look at other features of implementation, including number of completed visits, so that gets at the dosage of the program. In terms of maternal behaviors, we'll be looking at tobacco cessation, health visits in terms of both prenatal and postpartum health visits, other behaviors like breastfeeding, as well as use of the emergency department. And then finally, infant health. And so this includes outcomes related to low birth weight and preterm birth, well-child visits, vaccinations, and incidence of childhood injuries. And so with this particular aim, we're also interested in exploring the outcomes and relationship between collaboration and outcomes among subpopulations of nurse-family partnership families. And so evidence has shown that NFP benefits the families who are experiencing the greatest adversities. And I think this particular question, we're interested in aligning it with current issues. And so we know that COVID-19 is disproportionately impacting families and groups of racial ethnic minorities. And so we want to be intentional in exploring the influence of that, as well as the influence of structural racism on certain subgroups within nurse-family partnership, including our families who identify as being Black, African American, and or Latinx. And so really thinking about how can we be intentional in capturing those effects within this broader systems alignment project. And so from this work, first in aim 1, measuring collaboration, and then aim 2, looking at the relationship between collaboration and outcomes, then leads us to our third and final aim, which is to develop best practice models. And so in this particular aim, we're hoping to identify top performing sites who are both highly collaborative and have great systems alignment with healthcare, public health, and social service sectors, and have really great program outcomes. And so identifying those high performers using a positive deviance approach to then conduct qualitative case studies. And so the goal of these case studies then is to really explain some of those relationships we saw quantitatively and understand what those best practices might be, what those activities and dynamics are for better collaboration and systems alignment, and ultimately develop best practice models that might include financial mechanisms that we could test in future studies. And so I've provided an overview of the 3 aims and methodology for this particular project, and it kind of alluded to some of the pre-work that we've already done, not some, over the last 3 to 4 years that we've done in exploring what collaboration looks like in a nurse-family partnership. And so I wanted to take some time to talk through some of the work we've explored already. We conducted in-depth qualitative work with over 100 nurse-family partnership staff members, families, as well as cross-sector providers to understand more nuances of what that collaboration practice looks like and what's successful. We've translated those qualitative findings into a survey instrument that we implemented in 2018 and we'll be using and adapting for this particular project. And started looking at the associations from collaboration measured at that one point in time in 2018, associations between collaboration and outcomes. And so that's what I'll talk about here next is a teaser in some ways of some of the relationships we found, including positive associations with client retention, positive associations between collaboration and smoking cessation, in particular prenatal smoking cessation, and some mixed associations between collaboration and childhood injury and unintentional ingestions. And so here's a table with some of our early results, and I'll walk through this for the less research inclined. But on the left-hand side here, you see our predictors, and those are really our collaboration measures. We have relational coordination with a range of provider types. We have structural integration with a range of provider types. And so this is just what's showing the associations between our collaboration measures and our outcomes. Note that the outcomes here are including client retention at birth. So the top row shows our outcomes. We also include client retention at 12 months, prenatal smoking cessation, use of the emergency department for injury, childhood injury, and use of the emergency department for unintentional ingestion. And so these are adjusted odds ratios controlling for client, nurse, and agency level factors. And what you're seeing in the green shaded cells are the significant associations. And we see this as, there's some interesting things going on here. And so I'll draw your attention specifically to 2 pieces. And so the first red box here highlights the relationship between relational coordination with substance use treatment providers, and in particular client retention at birth. That's the second column. and prenatal smoking cessation, which is the fourth column. And so here what we're seeing is that better coordination with substance use treatment providers is associated with increased likelihood of being retained at birth, as well as increased likelihood of clients stopping smoking prenatally. And then I'll draw your attention to the second red box, which looks at the relationship between structural integration with child welfare. And so that could be your local child protective services or child welfare system. And we're seeing, again, positive associations between structural integration with child welfare and client retention at birth, in that second column. And then that effect or that association is retained when we look at client retention at 12 months. And then in the very far right-hand column, we see the negative association with emergency department use for ingestion. So all of this to say that we're starting to see some relationships, and that perhaps collaboration does matter in how we're measuring collaboration, but the exact dynamics are challenging and complicated to interpret. So in this early work, we're seeing relationships in the sense of better coordination with substance use treatment providers, and better integration with child welfare may help to improve client retention, but we need to do more research to better understand the relationship, particularly between collaboration and these maternal reported behaviors, which leads to why we're doing this particular project, and in particular, what we're hoping to learn. And so over the next 2.5 years through this Systems for Action project, we're hoping to provide additional evidence that collaboration is associated with improved outcomes, and not just the ones that I showed you, but some of the other maternal and infant health outcomes that I spoke to earlier on in our presentation. In particular, we're hoping to understand what those effects of system alignment looks like and thinking specifically about the financial alignment, comparing NFP sites that are being financed by healthcare systems versus those who are financed by social service sectors. This will be the first time we're measuring collaboration in nurse-family partnership over time. Like I mentioned, we've implemented a survey in 2018, and through this particular project, we'll be able to measure any additional collaboration changes over time. And then finally, intentionally integrating health equity into how we're conducting this research, as well as how we're disseminating our efforts and integrating these efforts into practice. And really thinking about how do we develop strategies and practice efforts for NFP nurses to integrate trauma, violence, informed care into what they do to best serve these families. And so that then leads me to the implications of this particular project, an intentional integration of what we're learning back into nurse-family partnership nursing practice. And I'll let Chris speak to that a little bit here in a second. But we're also thinking there are learnings to be had for future site development for nurse-family partnership in terms of new sites that want to be implementing NFP in their communities. Ultimately, we would like to maximize our nurses' productivity to best serve those families we know would benefit the most from nurse-family partnership participation. And those are the families who are experiencing adversities in our disadvantaged situations. And so, yes, this project is embedded within the nurse-family partnership setting. Well, we believe that our work is also relevant for broader coordination and systems integration efforts. And so other public health entities or evidence-based prevention programs that would like to be aligning and should be aligning their efforts with healthcare and social service settings. And so with that, I'll pass the baton back to Chris to wrap us up and provide some commentary on integrating these project findings back into nurse-family partnership healthcare integration work.
Great, thanks, Venice. If you want to go to the next slide, or maybe the next slide. There we go. So Nurse-Family Partnership is super excited to be a partner on this project with the University of Colorado. Nurses in any area of nursing work as part of a team. It's part of the practice of nursing. And this is clear, it's obvious when you see it in hospital settings where nurses work alongside many other disciplines caring for patients. We know that nurses in NFP have always had a level of collaboration with other services and providers to care for families in NFP. We've seen some great initial findings that Venice highlighted for us, and her early work is a great start to exploring collaboration really as a factor in NFP. This research now is going to give us the opportunity to dive deeper into questions we've had about collaboration in NFP. To what degree do our nurses collaborate? What helps facilitate these collaborations? And do they make a difference? It's really going to shine a light for us on what's happening with our nurses' practice and what are the organizational and structural factors that can help or hinder their efforts and make an impact for current and future sites. And part of what makes this particularly meaningful is that this is being informed by the implementation of NFP, as the National Service Office has been working very closely with the research team at the university, and that we'll continue to partner with them on this current research. In this way, I think the work really is translational. Practice has been deeply informing the research work, as well as Venice's research, and what's coming out of the research that's been done and what will be coming out is in turn informing our practice and our opportunity to improve nurse-family partnership with the National Service Office. So we think that the research studying collaboration and our work on integrating more deeply with healthcare and services is very critical. Right now I'm going to touch on a few points that you see here on the slide. First, this really aligns well with nursing practice and may impact nurse satisfaction. Community health nursing has a rich history in maternal and child health, and nurses have always been a part of healthcare. Having NFP more closely aligned and integrated is a good fit for NFP to deliberately explore and support. As Venice mentioned, we think this might have an opportunity to improve maternal and child health outcomes. NFP is grounded in the evidence. It makes logical sense that if NFP nurses are in the home, developing strong therapeutic relationships with families, and they can make those connections with the rest of the healthcare system, that we'll see greater improvements to maternal and child health outcomes. But I don't think we've really directly looked at the outcomes in NFP and whether or how they tie to the practice of collaboration. And while it's important for nurses to be able to connect with other systems, it's even more valuable for families to have the ability to advocate for their own health and needs. This is a key underlying theme in NFP, and we think that this work will really be assisting our families in managing their health and their experiences of care. NFP nurses will sit with a mom while she makes a call for things she might need. They'll provide coaching and support on her on how to navigate the health system and follow through on what to ask and what to say. So evaluating how our sites and nurses are positioned, with what ease they're able to communicate, coordinate, and engage with other systems will be very valuable to learning how we can support our sites and our nurses in these skills, but ultimately to help their moms advocate for themselves long after the NFP nurse is gone when the baby turns 2. Additionally, shifting gears a little bit, this work can help improve our NFP sustainability. We're always looking to sustain our services with our families now and to grow to serve more families that could benefit. With greater integration and collaboration, there's likely to be more awareness of NFP, and especially now with the increased focus from healthcare payer and delivery systems on social determinants of health. This is not a new concept, but what is new, I think, is an increased awareness across systems and acknowledgement of the need to explore how do we address determinants effectively. NFP nurses and community health nurses broadly have always been deeply steeped in addressing multiple determinants of health. So this work really pulls a couple of elements together between what's happening at the community level and the rest of the healthcare system. We also know changes have occurred with healthcare funding, the use of capitated care, and innovations like value-based payments. States and managed care are very interested in how NFP can impact HEDIS measures like timeliness of prenatal care and adherence to postpartum visits and other health outcomes of interest to states and managed care. And this research will help us better understand how NFP can work within the various structures and make the case to be part of state Medicaid plans, payment structures, and work with managed care organizations. Closely related to that, there's an opportunity to potentially reduce overall healthcare costs. We've seen numerous times anecdotally through the stories of NFP nurses assessing, intervening, and following up on health issues like preeclampsia, maternal substance use, both maternal and child health issues, as well as mental health diagnoses and needs. We regularly hear the stories of where nurses were able to assess and get a mom or baby into care that she needed that she might not have received otherwise. These stories really point to a cost savings for healthcare, and we think we may be able to see a greater impact in this area with increased collaboration. As I said, NFP is thrilled to be a partner on this project and support this valuable research. We'll learn a lot by studying this topic that will not only impact NFP, but it's going to have real lessons and insights for many health and social services in how we collectively work together to improve health and create healthier communities. And I'll close by saying thank you to the University of Colorado team for their work and to the Robert Wood Johnson Foundation Systems for Action for supporting this valuable research. With that, I think we go to Q&A.
Thank you so much, Chris, and to Venice and Greg as well, for walking us through how you explore ways to expand the reach and impact of the NFP program using multi-sector alignment. So we'll start off with a few questions. As we mentioned before, if you have any questions for the presenters, please enter them into the Q&A box. We have a couple, so I'll just go ahead and get us started, and I'll direct this question to Chris. And this is a two-part question. What are key provider types and institutional partners that are necessary for NFP to collaborate with to deliver the program with fidelity? And is there any way in which fidelity to the program could inhibit programmatic growth and impact?
Great question. So a couple of thoughts. As far as provider types or organizations to deliver nurse-family partnership, that is the role of part of the role of our office is exploring those conversations when a partner is interested in nurse-family partnership. The model fidelity is really the recipe, if you will, to deliver nurse-family partnership based on the model elements. And what we'll look at is how those elements align or might need some support locally to be able to do nurse-family partnership. So an example I like to use a lot is our partner in Indiana is Goodwill Industries. We think of Goodwill as a place to bring your stuff, right? And they came to us several years ago and said they wanted to do nurse-family partnership. Obviously, it means hiring a nurse, and they had never hired nurses. So that was an area that they're a great partner, very mission aligned, very driven to service to vulnerable families, but needed a little support on working on hiring nurses and how to employ and do a more health-oriented type of intervention in addition to the more social services that Goodwill is traditionally oriented in. As far as potentially inhibiting growth and impact, as I said, I think it's really the recipe, and we really do work closely with our communities to see how we can do this. So a lot of it is contextual and is about having those conversations to figure out how to make this work and use the strengths of the community and the organizations to do this together. So happy to follow up more on that conversation. I've been an NFP in a variety of different capacities for a long time, and I've really seen some changes over the years on how we've approached model fidelity and supporting our local sites. But happy to follow up individually if that's of interest to the person that asked this question.
Awesome response, and of course, as you can see from the slide, folks will have access to contact information from our presenters today if you do want to follow up. So, and this question can go to any of our presenters today, but we'd be curious to know what your thoughts are on the generalizability of your research findings to other home visiting programs.
right, Chris, maybe we'll give you a break since you talked Venice. You wanna fight me for it?
Since you started, you can start and I can follow up if needed.
Yeah, I think so. So obviously, this project is really grounded and done in partnership with Nurse Family Partnership. Those two partnerships in a row. Sorry about that. But I think we absolutely see the findings and the implications of this research that would be relevant to other home visiting, and actually even broader, to help to inform and think about broader systems functioning and collaborative relationships and breaking down silos that exist in these various sectors. I think that's been a perspective that we've brought to previous research that we've been engaged in with Nurse Family Partnership. And it's certainly a perspective that we bring here as well. I don't know if there's anything you want to add to that, Venice.
No, I think that was great. I think in addition, there's definitely lessons learned, I think, that are applicable for other home visiting programs, but knowing that the structure and implementation of home visiting programs vary across the nation, I think it's just understanding contextually what is it within specific communities more so than the home visiting program itself might be something there as well.
Awesome. And for another question for our researchers, do you anticipate that COVID-19 will affect your evaluation, your methods, or your results? And do you have any ideas for how you might adjust evaluation approaches to take into account the effect and impact of COVID on initiatives like NFP?
Yeah, this one's a big one. I'll stall here a little bit by saying we think a lot about and talk a lot about what are the implications of all the current events, including COVID, on the research project, and how do we need to adapt and be thoughtful about pivoting. So that's a really great question. I'd say I think we've got some ideas, and if just to be totally honest, I think we're still thinking through what are all the implications and how can the program adapt. Maybe I'll pause there really quickly. Venice, is there anything you want to add, or do you want me to go out on a limb and just confess some of the initial thinking we've got?
I think I'll just say a piece about how our nurses have transitioned to telehealth over this time. And so I think that's a piece of it as an maybe intermediate outcome that we're interested in looking at is the occurrence of telehealth visits. But I'll just stop there and let you, Greg.
Yeah, there's a bunch of stuff. Yeah, and so this might be one of these responses that generates more questions than answers, but maybe this is just the nature of the current situation. So I think what Venice talked about in terms of the transition to telehealth is a big piece. I think the other way in which we think about the effects of COVID are that those impacts are going to be most concentrated amongst the most disadvantaged segments of the population, which is the target population for NFP. And one of the ways in which we've talked about this is that, well, the NFP has been running this entire time, and that all of the measurement and the engagement with the clients is a kind of an interesting window to look at the impact. So we've talked about looking at assessments that happen within the NFP that just kind of fall into this broad category of just like broad categories of strengths and risk and what are outcomes as kind of a window into what type of impacts have COVID had on disadvantaged segments of our particular population. I'll say the other thing that we think about is, and maybe hopefully this came across in our presentations, when we think about collaboration and the need for collaboration and broader systems functioning, we see that being the greatest for those clients and that segment of the population that are at the greatest need. So simultaneously, we're thinking about how can we measure, adapt. We know the program is going through certain changes like the transition to telehealth, and that the underlying dynamic that we're looking at is what we hypothesize is more important given the strain on society as a whole and the concentration of those effects on the most at-risk populations. So I think I did what I just promised, which is generate more questions and maybe not answer as many. But maybe I'll pause there.
Okay, great responses. We have a few other questions, but are a little short on time. So I'm just going to randomly choose one for us to wrap up on. Okay, so one question that we've gotten, so what are the age range of NFP clients in the years of experience on average among nurses? And how do the effects of the collaboration across sites and systems vary across teen and adult mothers and new and experienced nurses? What are the implications of this line of investigation? So we'll end on a doozy, and I'll direct that to I'll direct that to Greg if you want to take a bite at that apple.
Yeah, sure. I might not be the most qualified person in the presenters to answer this, but what's the age range of NFP clients? It's highly variable. NFP, unsurprisingly, because it's serving first-time, it's focused on first-time high-risk moms, tends to serve very, very young mothers, right? So while there is variation that exists there, there's a heavy concentration in the very young mothers. In terms of years of experience among nurses, this is also highly variable. Of course, the program has brand new nurses that have never served in the NFP before, and there are also nurses that have been serving since, I think there are some nurses that might go back to when community replication first began. So we're talking decades of experience. And there's a difference there, and I would say in general, those nurses with more experience are more effective at functioning within the program and serving their clients' needs. I think I found the question that we're here. So how do the effects of the collaboration across sites and systems vary across teen and adult mothers and new and experienced nurses? I'm going to reframe that and say that I think what we have seen so far in the preliminary work that we've done is that collaboration varies quite a bit at local sites from sector to sector. And in general, collaborative relationships are the most important when you're serving the highest risk mothers, right? And so, and then the nature of that collaboration kind of needs to map onto the needs of that particular mother. So a hypothetical example is a mother that is struggling, a young mother that's struggling with substance abuse. Collaborative relationships with substance abuse treatment in NFP could be is likely to be a really critical collaboration dynamic to effectively meet the needs of that particular mother. So and maybe this hypothetical example is just illustrating one of the points that Venice made earlier, which is these collaboration dynamics are really complicated, I guess, which makes them all the more important for us to understand better and research, and that's what we plan to do here. Hopefully
Greg, I can jump in here for a second.
Yeah, thanks for the save, Venice. Go for it.
For those who want actual numbers, our client age ranges are 11 to 49, with a mean age of about 23. For our nurses' tenure in the program, like Greg mentioned, we have some very new nurses who are brand new and may have been with NFP for less than a year, up to those who've been with us for over 30 to 35 years. So we have a lot of variability in that, and the mean years of tenure is about 6 years. In terms of impact on the outcomes we're looking at, I think these are both factors that we control for in our analyses, but what we're seeing is that older clients are tending to stay in the program longer, and that, of course, nurse tenure does have an effect as well. So hopefully that answered those questions.
Thank you so much for the lively discussion. Dr. Gregory Tung, Dr. Venice Williams, and Chris Aristides, much appreciated. If attendees would like to receive a certificate of completion for today's ResProg webinar. Please complete the survey at the end of the session. It will be emailed to you. Also, with that email, you'll have access to a recording of this research in progress webinar along with PowerPoint slides. So be on the lookout for that. And also, if you would like to learn more about this study and the others funded by Systems for Action, please check out our website, systemsforaction.org, and follow us on Twitter as well. And for anyone who is on this call who either has ongoing or recently completed systems alignment research and would like to see the impact of that systems alignment mechanism on the COVID-19 response and recovery, we have a call for proposals out right now, and we're taking letters of intent, which is optional, by July 20th. Full proposals are due August 5th. If you would like to learn more about this funding opportunity, also check out our funding opportunities page on our website, where there'll be a link to our informational webinar, giving more information, and also the CFP itself. And with that, we look forward to seeing you all again for our upcoming webinars. Our next one will be July 22nd, same time, same place. We'll be hearing from another new study out of University of Connecticut looking at transit treatment and the effectiveness of transit systems to improve substance abuse and mental health in Connecticut. And another one will be August 5th. Where you'll hear another new project coming out of WashU, and they're investigating systems alignment of multi-sector agencies to address child maltreatment in St. Louis. Thank you again to our presenters and for everyone who was able to attend. We want to thank the Robert Wood Johnson Foundation, and see you again on the 22nd.
Thank you.